Your passcode has been confirmed. If you need technical assistance during your call, press *0.
After the tone, please state your name, followed by the pound sign.
I'm sorry, we did not get your name.
After the tone, please state your name, followed by the pound sign.
I'm sorry, we did not get your name.
After the tone, please state your name, followed by the pound sign. This conference is in silent mode. There are 20
parties in conference, including you.
Questions, and you'll have to press *6 to individually unmute your line at that time. If you have a question, you can electronically raise your hand by accessing the Q&A tab on the menu bar of your webinar screen and click on the hand icon in the upper right corner. This will display your name to the moderator. I will call on participants as their names are displayed, and you can raise your hand during the presentation, but we will wait until the discussion period to address those comments. Also, this session is being recorded. Today's topic is improved survival of children and adolescents with sickle cell disease. Charles T. Quinn earned his MD in 1994 and his MS in 2008 at the University of Texas Southwestern Medical Center in Dallas, Texas. He also completed his residency and chief residency at Children's Medical Center, Dallas, and University of Texas Southwestern Medical Center, respectively, in 1998. He also maintained certification in pediatrics and pediatric hematology oncology. Dr. Quinn's main interests and expertise are in patient-oriented and translational research in sickle cell disease and thalassemia. His formal clinical and translational research training has included the NIH K-30 curriculum in patient-oriented research, the Clinical Research Training Institute of the American Society of Hematology, the NIH K-12/KL2 Clinical Scholars Program, and a master's degree in clinical sciences. Dr. Quinn is a member of the editorial board for Pediatric Blood and Cancer and the board of contributing editors for the Hematologist. Dr. Quinn is on the medical advisory board for the Cooley's Anemia Foundation, and he is a member of the Committee on Educational Affairs of the American Society of Hematology. Locally, he is the medical director of the Ohio Department of Health Regional Sickle Cell Services Program, Region 1. And at this time, I'd like to turn the webinar over to our presenter, Dr. Quinn. If you could please unmute your line by pressing *6 at this time, and you can address the audience.
Good afternoon. Can everyone hear me?
Yes, we can. Thank you so much.
All right. Thank you. Well, thank you for taking time out of your schedule to join us today, and I thank the CDC for inviting me. The topic today is improved survival of children with sickle cell disease, children and adolescents. So I'll go on to the first slide. And, to start out with this presentation, I think we need to look back, and this is the headstone of Walter Clement Noel, who you can see died at around 32 years of age, and he was the first recorded patient with sickle cell disease. So I keep that in mind, at least from the very beginning, this was a disease associated with shortened life expectancy. Now, about the time that life began for me, I was born in the late 60s. Roland Scott had published this estimate of survival of individuals with sickle cell disease in the United States. This wasn't a birth cohort by any means, but this was an estimate. And what you can see here is that there's a steep decline in childhood mortality. The mortality has a steep decline in childhood. That the median survival was about 19 years. But interestingly, there were a number of long-term survivors, even back here in this report from data up until 1967, even though the report was published in 1970. So if we move forward just a little bit and start talking about newborn inception cohorts, where individuals with sickle cell disease are identified at birth by universal newborn screening and followed forward in time, the Jamaican cohort study was probably one of the first on the scene here. And these are data that were published in 1995, but what you see here, this survival curve is for the first third of the Jamaican cohort. Accrual began in 1973, and it has continued, and I'll show the continuation dates in a little bit. But if we just look, they divided the cohort into thirds based on year of birth. We can see for individuals born between 1973 and 1975, that estimated survival to about 14 years of age was only 73%. With the addition of prophylactic penicillin as the only significant or known intervention to the third of the cohort, you can see that overall survival improved from 73 to 85% at about 14 to 16 years of age. So a significant improvement in survival from birth just with the addition of prophylactic penicillin. Now, what about looking beyond in the past survival curves here? You can see that the follow-up goes up until about age 18 years. What about looking beyond that? And so the cooperative study of sickle cell disease, which is a landmark study in sickle cell disease that we all know about, multiple publications, multiple analyses, demonstrated, and this wasn't in total a newborn inception cohort. There was a newborn cohort, which I'll talk to you about, but these data are estimates of survival for the entire population of sickle cell disease, as best inferred from the individuals in the CSSCD. And I think we know, all of us who take care of sickle cell disease know these numbers by now, and that at least in follow-up through the mid to late 1980s, the probability of survival, the life expectancy, for individuals with SS who are male was 42 and 48 for females. But in those with sickle hemoglobin C disease, on the other hand, life expectancy approached that of the normal population of African Americans for both males and females. So data published in 1994, but with follow-up through the mid to late 80s, 42 and 48. And we'll come back at the end of the talk and see if there have been any updates to this life expectancy number. Now, as I mentioned in a previous slide, there was an infant cohort, which was defined by entry to the CSSCD at less than 6 months of age. Many of these were identified by newborn screening, but not everybody. So not truly a newborn inception cohort, but getting there. And with the limited follow-up published by Gill in 1995, the survival at 4 years of age at least was 95%. So you can see with time, and you can see in the color-coded, I have a pointer, you can see the color coding here. And so we can see with the progressive increase in time, you can see some progressive improvements in survival, and we'll talk about some of the reasons for this in some of the upcoming slides. All right, so this is just a comparison of those two cohorts that I've talked about, the Jamaican cohort with enrollment from 1973 to 1981, CSSCD through 1988. We can see that the Jamaican cohort was a newborn screening cohort, a newborn inception cohort. Uniform penicillin prophylaxis was not applied to everyone in the cohort. We saw the difference that it made in the Jamaican cohort, but we don't have that same, at least that same analysis for the CSSCD. So back in the early 2000s, I wondered, are there any contemporary cohorts that could guide us here and give us current data? And so we went about in Dallas creating our own cohort of sickle cell disease. And so the contemporary cohorts that I'll call them, and by no means these aren't the only, but the two that I'm going to talk about here are the Dallas newborn cohort and the East London cohort. And you can see the publications and abbreviated references below. All right, so what's the Dallas newborn cohort? And so those of you who don't know, I was in Dallas before. Now I'm in Cincinnati. One of the main things that I did in Dallas was to establish the Dallas newborn cohort, which is ongoing, by the way. And so still Dr. Buchanan, Dr. Rogers, and Dr. McCavitt are still actively accruing to this cohort, and hopefully we'll have ongoing updates as time goes on. So as I mentioned before, this is a cohort identified all by newborn screening, universal newborn screening for hemoglobinopathies. Everyone given prophylactic penicillin, at least those with SS and S beta 0, included the 4 main genotypes, and accrual is ongoing. All right, and so if we just take a look at the differences here, we can see that accrual begins in 1983. The other two cohorts, accrual is wrapping up around then. Accrual is ongoing. You can see the relative size of the cohorts here. We have 88,857 patient years of observation, so a relatively large period of observation. And we can see all had uniform penicillin prophylaxis for those with SS and S beta 0 thalassemia. And these were data through 2007, as you see here. All right, so what did we show? And many of you have seen this already. This was published in 2010. And for those with sickle cell anemia and sickle beta 0 thalassemia, we found that overall survival, all-cause mortality, considering all-cause mortality, overall survival at 18 years of age was about 94% with the confidence interval that you can see there. So the 95% confidence interval, at least 90% at the worst, we would estimate would survive until adulthood, defined at least here at age 18. As you might imagine, those with sickle hemoglobin C disease and sickle beta plus thalassemia fared better, and 18-year survival estimates was 98.4%. We did something similar to the Jamaicans and divided the cohorts into thirds to try to see if we could see any progressive improvements in survival over time. And you can see the thirds of the cohort shown here, and these are by birth year. And what we see is a suggestion of progressive improvement in survival over time. And the incidence of death is shown here in the box, 0.6, 0.3, and 0.1. Those are the incidence in number of deaths per 100 patient years. And so a progressive improvement in survival and decrease in incidence of death over the eras of the cohorts, as we call them. Now, what might be going back? What might be some of the explanations for this? I mean, there wasn't something clearly that happened like penicillin, as you saw when it was introduced into the Jamaican cohort. We didn't have one thing. So we tried to look and see if there were improvements perhaps in the quality of care that we delivered over the course of the cohort. And so on the top here we see one marker or indicator of quality. Age at first visit. Of course, we'd like to get these individuals, these babies, into our clinic as soon as possible after identification by newborn screening. And of course, we set as a goal to have them in by 90 days. You can see over time, there was a progressive improvement in the time at which they presented to us at their first visit in our center. And that is a proxy for, or at least an opportunity to prescribe something life-saving like prophylactic penicillin, immunizations, and educate about fever. And looking then also at age at first penicillin, we can see a similar sort of progressive improvement. And by 2007, which this was the cut point for the analysis here in the 2010 publication, most individuals were started on penicillin by 90 days of age after having been seen in our clinic by that same period of time. So here we showed that there was, at least in these two indicators of quality of care, there was an improvement in these indicators that was simultaneous with the improvements in quality. And here's just showing you those numbers. Now, when we looked at the causes of death by year of death, rather, this is what we see. And there are lots of different causes of death, and I tried to categorize them here. We'll go over some of the individual ones shortly. But acute chest syndrome or multi-organ failure syndrome, each of these dots represents a death. If you look here, here's sepsis, and these are neurologic complications, and this is everything else but is potentially sickle cell disease related, and then unrelated to sickle cell disease. But we'll touch on this in the next slide. One thing to point out here that I thought was interesting is that if we look at sepsis, the deaths from sepsis occurred, well, the green one is the H. flu sepsis death, we haven't seen any of that since the conjugated H flu vaccine. And so far, the same holds with the conjugated pneumococcal vaccine. And so with preceding years, especially after 2000, you start seeing that acute chest syndrome and multi-organ failure syndrome are the predominant causes of death in the cohort. The other thing, too, to note is that all the deaths that are indicated in red are those that occurred shortly after transition to adult medical care, or around the time of transition to adult medical care. So, although the death rate is decreasing, mortality is improving, you know, there still are kids dying from sickle cell disease, and I tried to figure out, well, how does that compare to a child born in the state of Texas who was black, born in the same year, for example? And you can do some simple epidemiology and calculate the number of expected and observed deaths in the cohort. And what that showed, and these are data that might be applicable to the first third of the cohort that I showed you, the first and the second third. But even though the death rate the incidence of death is decreasing, the mortality ratio, the standardized mortality ratio, suggests that, or indicates that the risk of death is 19-fold higher in those with children with sickle cell disease, even with the current improvements in survival. Hopefully, this is lower with if we considered individuals born, say, in 2000 or 2010, but at least, you know, consistent with the early part of our cohort, compared to African American kids born in the same year in the same state or even in the same county, 19-fold increased risk of death. Now, these are the causes of death that we saw, and the interesting thing that I think is just all these causes of death that are potentially unrelated to sickle cell disease: trauma, drowning, myocarditis, congenital heart disease, other things going on. You'd think that for such a relatively small cohort to see all these things would be unusual. What I take home from this is that I think that if you have sickle cell disease and you have something else, you get into a car accident, you get myocarditis, I think that because you have sickle cell disease, you're more likely to die from some of these other complications. So sickle cell disease increases your risk of death. But I think if you have sickle cell disease too and you get another illness or another injury, I think your risk of mortality is increased because you have both at the same time. Now, I can't prove that statistically, but I think that's in part what these data show. All right, now, of course, we're not the only cohort out there that's a newborn inception cohort that's modern. The East London cohort has similar dates of enrollment, and these circled, or these dates that are in parentheses, just indicate the time at which the last analysis was published, and so enrollment is ongoing. But this is also the East London cohort, a newborn screening cohort with uniform penicillin prophylaxis and a substantial size. And so what did that show? No surprise, also excellent survival. And you can see this is from 1983 to 2006, the East London cohort. You can see the amazing, excellent survival of individuals with sickle cell anemia throughout childhood. And I think part of the reason that this is so good is because of the nationally coordinated healthcare system, and it's seamless from provider to provider, or at least seamless compared to our system. So if we look back from that original slide that I showed you that Roland Scott had published in the JAMA, you can see, and then because if I go back here, look that these all start at 0.7 just to show the spread. So if we just take a step back and make the axis go down to 0, this is the sort of improvement that we've seen over time. And of course, what might be some of the reasons for this? Well, I think we all know hydroxyurea, improvement in quality of care, improvement in supportive care, that sort of thing, in addition to prophylactic penicillin and universal newborn screening. So lots of reasons for this improvement over time. And so fortunately, at least for children, we're starting to see a flat line up here, and so that's fantastic. But the bad part is, as we'll point out, is that this line doesn't stay flat, but it seems to fall off, begin to fall off alarmingly after the transition to adult care. So in summary for this first maybe third of the talk, you now see that have shown that most children with sickle cell anemia and sickle beta zero thalassemia live to become adults, and nearly all of those with hemoglobin SC and sickle beta plus thalassemia live to become adults. And of course, chest syndrome and multi-organ failure syndrome are now the leading cause of death in children. And, I didn't mention this in the beginning, but I did want to say explicitly that I'm talking about survival data, at least for, especially the modern survival data, for developed nations like the United States, Europe. I don't do justice to survival data in developing worlds or in Africa, especially where sickle cell disease has the greatest burden. So that is one caveat. Now, even though childhood survival is so much better now, it's not zero. Mortality is not zero, and we've shifted the mortality of young adults. And what we saw here in our data is that the transition period from pediatric to adult medical care was associated with a very high risk period for mortality. Between the first and the second publications of the Dallas newborn cohort in Blood, the new deaths that occurred in between those two publications, they were all in the transition period from pediatric to adult medical care. So obviously, that's a problem that needs to be addressed. So even though we've demonstrated things are looking good, I do think that cohort studies are still needed to track our progress and identify needs for improvement, and especially cohorts that go beyond childhood. And we also need to look at outcomes besides death, because it's increasingly uncommon in childhood, like I mentioned, in developed nations. And other measures such as quality of care and other indices of morbidity should be included. All right, I'm going to transition a little bit. We talked about survival, mortality. What about risk of mortality, prediction of adverse outcomes? We'll talk a little bit about this before coming back to survival and mortality. So a related part of the talk, but a little bit different. So this is of no surprise to anyone on the line that sickle cell anemia is quite variable and often unpredictable. And one of the challenges that people have recognized for longer than I've been around is that it can be difficult to identify young children at highest risk of adverse outcomes before organ damage has occurred. Now, there is an argument that you should consider all children to be at highest risk of adverse outcomes, so that's also true. But what about those that are at the highest of the high risk? And that's what we're talking about here. And in this case, perhaps a robust predictive model would allow early tailored therapy to prevent adverse outcomes. Now, I do recognize that there is also an argument that you should just start, that people might make the argument that all patients should be started on a disease-modifying therapy. And I think that's not an unreasonable argument. But that's the subject of a different talk, I think. So, and this is just some examples of the phenotypic heterogeneity. So if we just look at what we see here is histograms of vaso-occlusive event rates. So this is how often does pain occur in the cohort, how often does chest syndrome occur in the cohort. And you can see that it's markedly left-shifted in both. But the other thing that you can see up at the top, I hope, is that there are a large number of individuals that do have very frequent episodes of pain in chest and other complications, but only pain in chest are shown here. Wouldn't it be nice if we knew who these were as newborns, so we could maybe tailor our intervention or be more aggressive or be more thorough? Not that we shouldn't be aggressive or thorough with anyone else. So what about predicting outcomes? You know, a grand example is the use of TCD, transcranial Doppler ultrasonography, to identify children at highest risk of stroke to implement chronic transfusions. That's a great example, and we've reduced the incidence of stroke in the United States and in Europe from sickle cell disease, so it's been an efficacious and effective. There's still room for improvement in terms of effectiveness, but it has been an effective tool. The problem is that besides stroke, other serious complications of sickle cell disease are difficult to predict in individual patients. We know some risk factors for the population, but identifying the individual, that's where it becomes tricky. And here, at least in the past, but maybe less so, clinicians, and perhaps less so now, clinicians would often wait for severe disease to become manifest before initiating some sort of disease-modifying intervention. But I think we all know that there is some movement in the field, perhaps away from this, but we're not completely there yet. So when we think about disease modifiers for the population, of course, sickle cell genotype, SS versus SC. Fetal hemoglobin is probably one of the strongest predictors of outcome, mortality, just about anything that you can think of in sickle cell disease. The higher the fetal hemoglobin, the better. Your beta globin cluster haplotype, which is really linked to fetal hemoglobin, and your alpha globin gene copy number. And this is just a brief review. And so what might predict death, at least in the population, but not necessarily with great accuracy for the individual: a lower hemoglobin concentration, a lower hemoglobin F concentration, and a higher steady-state white blood cell count. And you can see these same predictors. And most of these are predictors identified first in the CSSCD, and of course have been validated and found in other cohorts as well. But again, the problem that I alluded to before is, can we predict the most severe disease in an individual, somebody that would be especially anxious to approach early and start some sort of therapy early? Well, the problem is that it's hard to define the severity of disease because nobody really has a uniform, definite. Obviously, an overt stroke and death are severe, but once you have those, that's too late. And so we don't have a great measure yet, and so we tend to end up using composite or proxy measures such as, like I mentioned, death and stroke and frequency of vaso-occlusive complications, that sort of thing. Single complications, I think, are easier to define and therefore to predict, such as with TCD and using it to predict overt stroke. But really, we're going to, because this is a talk on survival in sickle cell disease, we're going to look more at global severity of disease, in which mortality is one of the outcomes. And so I think all of you in the field know about this landmark study, also of the comprehensive, the cooperative study of sickle cell disease published in the New England Journal in 2000, where Scott Miller and colleagues were tackling a very, very important issue. How do you identify those young kids? And let's see, next slide here. This was the early prediction model that was used in the infant cohort. And I showed you the survival data for those infant cohort. These are 392 children with mean follow-up of 10 years. And so the study looked at these early predictors: early dactylitis, severe anemia, and leukocytosis, and these are all defined here, trying to predict these adverse outcomes. And so it was a composite of different outcomes. This is, essentially a global, the outcome is some global measure, in a sense, of disease severity. And what the investigators were able to show, and what they did was identify those individuals at high risk were those defined to have a probability of severe disease of 0.36. And so looking back, could we define what the predictors were? Well, if you can see this dark line here, this is for individuals who had neither early dactylitis nor severe anemia. And if you had neither, then your risk of adverse outcome was low. But as white blood cell count increased, your risk increased. Now, let's say you had either severe anemia or early dactylitis, one or the other, but not both. Same sort of line with increasing risk with increasing white blood cell count. Of course, if you had both dactylitis and severe anemia, your risk of adverse outcomes was elevated from the beginning, and the higher your leukocyte count, the higher the probability of severe disease was in this cohort. So this was a great effort, easily identified predictors, identified early in life. Some of the potential downsides were that it had limited clinical utility because only 3% of the cohort actually had those combination of risk factors that predicted a twofold or more risk of disease. So you could identify a very small number of individuals at very high risk. And at the time that this was done, 56% of deaths were from infection. And of course, we don't see that anymore, and so one might wonder, are these early predictors, at least in part, predictors of death or infection? Just something to think about. And so we attempted to replicate this model in the Dallas newborn cohort, and this was published in 2008. And so there are several differences between the Dallas newborn cohort and the CSSCD. So we did our best to do a direct test. Some of the differences that newborn screening identified all of our members, all had prophylactic penicillin, and that our years of enrollment were shifted later. And so looking at those three predictors, early dactylitis, severe anemia, and white count, we didn't find, at least in our cohort, with the same outcomes as defined, that early dactylitis was a predictor. The odds ratio was 1. Nobody with severe anemia had an adverse event, and so we couldn't calculate an odds ratio. But we did see that with the leukocyte count, those that had an adverse event, their leukocyte count was higher with the mean difference between the two. So we didn't see any signal with early dactylitis and severe anemia, but we did show, as others have shown, the importance of leukocyte count in predicting mortality. And then if we looked at the individuals who had one of those adverse events, death, stroke, frequent pain, recurrent ACS, none of them was predicted by the model to be at high risk, and most were either predicted to be at low or medium risk. All were predicted to be at medium or low risk. And this just shows you that the model, as strictly applied to the cohort, was not better than chance prediction and had 0 sensitivity and 95% specificity. So at least as in our cohort, the CSSCD model was not particularly useful. And we had concluded, at least then, that the model shouldn't be used as the sole criterion to guide therapy. I think it's still something to consider, early dactylitis, severe anemia, white count. But we still need, if you're going to take the tack that not every child should be started on a disease-modifying therapy starting at 9 months, for example, as certain guidelines are about to show, that we still need an early prediction model. We're just not there yet. Now, I can't review every predictor of adverse outcomes in death and sickle cell disease, but a notable recent one, as we all know about, is the tricuspid regurgitant jet velocity. And this was the paper that everybody knows by Gladwin and al. At New England Journal 2004. And these were adults. Okay, so this is a predictor of mortality in adults, but several studies have shown that it's not a predictor of mortality, at least in children, followed through 18 years of age or so. It may mark them as having early mortality beyond the period which they were followed in their particular study, but at least as strictly defined by these studies, it doesn't seem to be a predictor of mortality in children. But in adults, those that have a low versus a high TR jet velocity, there is a significant difference in survival. So no matter what you think TR jet velocity might indicate, pulmonary hypertension, something else, heart disease, there's controversy there, but so whatever it represents as a biomarker, it does mark, at least you can say it marks an individual for high risk of early mortality, decreased life expectancy. All right, so what might the future hold? I don't know, so I just came up with some ideas here to talk about. And here again, I'm not talking about predicting an individual outcome such as overt stroke, but overall disease severity. And I'll just highlight 2 studies, and this was published in 2007, Sebastiani et al., and this was a network model to predict the risk of death in sickle cell disease, and lots of names that you would recognize in the authors. And so here, they looked at a fantastically large number of patients with sickle cell disease and took 25 clinical events and laboratory tests and did Bayesian network modeling to model the risk of death in 5 years. And so what the network model looked like is this here, and you can see the output here is death or stroke, and these are the different things that were measured and how they interplayed and how the risks fed into other risks. And so the bottom line is that knowing all of these different factors here, whether or not they had leg ulcers, for example, what their BUN and creatinine was, what their LDH was, the probability of death could be predicted. And so you come out with a score for probability of death within 5 years. And so this is 0.8 probability of death in 5 years. And look at age 2 to 18, age 18 to age 40, and greater than age 40. And then the patients that died versus the patients that didn't. And if their model was accurate, you'd expect a higher score in those that had later died. And you can see that here across all age groups, that scores that were generated were all higher for those that had died compared to those that didn't. But of course, there are some notable outliers here, but the minority. And interesting. Oh, and here's just other validation, looking at if you had experts classify the individual as having mild, moderate, or severe disease, and see that how the scores compared with that. So if someone said that this patient had mild disease, they tended to have a mortality score that was quite low compared to those with severe disease. And this is just another classification system as well. And then if you looked in the NIH pulmonary hypertension cohort, you can also see that those with severe disease had higher mortality scores, risk of mortality in 5 years. And then if you looked at those by TR jet velocity, the higher your TR jet velocity, which, as I showed you, is a predictor for mortality in adults, the higher your prediction scale was, your predictive score was. And these are the patients who were alive, and these are the patients that unfortunately had passed away. You can see that this relationship held true for both patients that died and patients that were alive. Yes. And I couldn't find this online anymore, but several years ago you could actually go and you can enter all these different things, all these different features of the patient here, and you can press this button and it would give you the probability of death in 5 years. And so I'm not sure what the authors have done with this or what they plan to do with this, but this is a glimpse of how the future might look, at least in terms of predicting disease severity. Just another study to point out as a proof of principle, monocyte protein signatures of disease severity in sickle cell anemia. This was published in 2009. And so, as I've shown you, and as you know, leukocytes are involved in the pathogenesis of sickle cell disease and associated with disease severity. We've seen that several times now. So here we just, a proof of principle. This is by no means definitive. We took 10 children with sickle cell disease, 5 male and 5 female, and looked as a proxy for overall disease severity. That's the best we could do, at least then. We looked at their 5-year vaso-occlusive event rate and did proteomic profiling and identified proteins that correlated with the disease severity. So these are what the data look like. And so these proteins were increased in individuals. These proteins were increased in individuals with high disease severity as defined by 5-year vaso-occlusive event rate, and these proteins were decreased in abundance in those with high painful event rates. And so, no need to belabor this, but there are certain proteins that were decreased in abundance that increased with increasing disease severity, and then there were proteins that decreased in abundance with increasing disease severity. And you can see the variety of different functions that these proteins might subserve. And so this is more of a proof of principle, and this could be done for genomics, metabolomics, that sort of thing. And I think advances in the field will probably involve something much more sophisticated than we have been using now. Complex prediction models using simultaneous predictors, sophisticated statistics, and all of the omics that you can think of, and of course novel biomarkers of disease severity. All right, so let's, in the last few minutes, come back to life expectancy in sickle cell disease. I still hear people quoting the life expectancy in sickle cell disease to be 42 and 48 for males and females with SS. Do we know anything more than this still? I mean, obviously things are probably better. At least this steep decline in childhood is no longer so steep? Has that translated into improvements in life expectancy overall? Well, we don't have a good U.S. cohort to tell us, and we don't have the exact answer that we need, but these were estimates, and these were estimates, these are mathematical estimates from the Jamaican cohort. So these survival curves are, of course, all survival curves are estimates, but these are mathematical derivations, these survival curves, based on their current event rates. And what this paper suggested, at least for the Jamaican cohort, at least at the 2001 publication date, it wasn't 42 and 48, as we often still quote, but the suggestion that life expectancy is maybe a decade longer, 53 years and 58 years. But again, these are mathematical estimates. And to wrap up in the last few minutes here, talk about a few words about the effect of hydroxyurea on survival. And so we've mentioned and talked about the utility of disease-modifying therapies all along. Well, what about people that take hydroxyurea? Do they live longer? And so the first evidence that came out, or the first, maybe not the first evidence, but the first reasonable piece of evidence was estimates from the multicenter study of hydroxyurea follow-up study. And they looked at mortality in patients with sickle cell anemia who had been in the MSH study and had ever been treated with hydroxyurea or not. If you just looked at the cumulative death rate, you can see that with placebo here, it appeared that there was an increased risk of death, but it wasn't statistically significant in this analysis. But if you take a look over here, if you stratify, if you look at the effect of fetal hemoglobin, you can see a clear improvement in survival, or decrease in mortality if your hemoglobin F were low, and a suggestion that mortality was decreased if you ever took hydroxyurea. But using a different analysis, not like this Kaplan-Meier analysis, they were able to estimate that adults who took hydroxyurea had a 40% decrease in mortality. And so you can see that this is statistically significant, but this is not. And so a suggestion of a difference. And of course, this study wasn't designed to answer this question, so trying to eke out as much information as we can from this excellent study. Now, fortunately, that's not all we know about hydroxyurea. We know that hydroxyurea is associated with improvements in survival in other cohorts as well. And published in 2010 in Blood was this adult cohort study of Greeks. Had a lot of individuals with sickle beta 0 and sickle beta plus thalassemia, as you might imagine, but also SS disease and other genotypes. And this is looking at all genotypes. And if you were treated with hydroxyurea, and then these are adults, 86% survival at 20 years, and compared to 65%. And remember, these aren't randomized clinical trials, and so can't directly answer the question as well as a randomized clinical trial would. But if you think about it, the ones that are on hydroxyurea are probably those with the highest disease severity, potentially. And so if you were to think about the bias, you'd think that the bias would be that patients with hydroxyurea would be more likely to have severe disease. Now, what about kids? There's some evidence in adults. Well, recently published in 2013 in the British Journal of Hematology was the Brazilian cohort study, which looked at children who were prescribed hydroxyurea or not. And again, not a randomized clinical trial, but I think it's the strongest. These are the strongest data that I think we're going to be able to get in this era, given the current usage of hydroxyurea. And I'm not saying that's a bad thing either. That individuals, children who took hydroxyurea, their survival 99.5% compared to those who didn't take it, 94.5%. So about a 4 to 5% decrement in survival if you didn't take hydroxyurea. Of course, this is time in months here, so this isn't survival into adulthood, but even early on. So we have evidence of a beneficial effect on mortality for hydroxyurea in both children and adults. Well, I have 1 minute left, so I guess I'm right on time. So final points here is that most children with sickle cell disease live to become adults in developed nations like the United States, like Europe. Acute chest syndrome and mortally organ failure syndrome are more common as causes of death than bacterial sepsis. And unfortunately, what we've done is just shift the, fortunately and unfortunately, we've shifted the burden of mortality. It's now young adults bear the burden of mortality. And it's this transition from pediatric to adult medical care that appears to be a very high risk for mortality. So we're transitioning children at a very young adults at a high risk period for mortality. And then, as I've shown, and as you know, sickle cell disease is highly phenotypically variable. We don't have great predictors. But what we do see, and there's hope for continued improvements in survival, is that hydroxyurea appears to improve life expectancy both in children and adults with sickle cell disease. And hopefully increasing use of disease-modifying therapies will further improve life expectancy and hopefully quality of life in sickle cell disease. So that was my last slide, and I think I ended right on time.
You did, Dr. Quinn. Thank you so much. You managed to pack a lot of information into exactly 45 minutes. This is now the time for questions for Dr. Quinn. So for the audience, please remember to unmute your phone by pressing *6. If you have a question and you're on the webinar, you can raise your hand electronically, and I'll call on you as your questions are posted. If you are only connected via teleconference, you can just unmute your line and ask the question out loud as there's a break in between questions. I don't have any questions in my queue, so if anyone has a question over the phone, you can go ahead and ask that now.
Difficult questions are not allowed.
And just a reminder for the audience, you'll have to unmute your phone by pressing *6 if you want to speak. I'll take that silence to mean that everyone's questions were answered during the presentation. I'll give a couple of, was that someone?
Yeah, this is Charlie Homer from NICHQ. Thank you. Fascinating conversation and wonderful data. So if you had a magic wand, what do you think your highest leverage strategies would be to further increase survival rates and duration?
Well, I think we'd have to focus on the initial place to focus is the transition between pediatric and adult medical care, and of course adults beyond that transition period as well, and some way of making that transition seamless. And that's a whole other talk. And transition is not something that I'm an expert on, but I think that's the next place that we really need to focus. These kids are being transitioned, these young adults are being transitioned at especially high risk period for mortality. And maybe that risk of mortality is because of biological issues. They have acquired progressive organ injury over time, and that's just becoming manifest in young adulthood. And some of it may be the system as well. Maybe if they were still in the pediatric system, touchy-feely, hand-holding, maybe those individuals wouldn't have died. But so it's complex, but I think we need to figure out why they're dying at the transition, and what we can do to prevent that. So we had to start somewhere, at least in this country, with the data that we have now, that was the transition period.
Thank you.
Hello, this is Ellen Werner from NIH.
Hello.
And hi, very interesting. Thank you so much. You did pull a lot of information together for us. Do you have any evidence, or have you looked at health behaviors and health risk behaviors in this adolescent and early adulthood population, just as they're transitioning? Because an increase in those more risky behaviors would certainly be consistent with that age cohort.
No, I agree, and that's yeah. I mean, so we can't just look at a purely biological disease-focused issues here. But I haven't specifically done any research in this area, but some of my colleagues here in Cincinnati are working on this. But yeah, you're absolutely right. But I can't speak personally to it. Of course, we see that. I can tell you that anecdotally. And it's being studied by some of my colleagues here and throughout the country. But you're absolutely right.
Thank you.
And it's not a problem not specific to sickle cell disease.
Right, yes, exactly. But it seems that if there is evidence and it figures in a risk prediction model, it's certainly amenable to intervention.
Yeah, that's an excellent point.
Thanks.
Okay, we have a question from Tanya Mitchell. She writes, you mentioned that transitioning to adult medical care is where the highest rate of mortality lies. What would you suggest could be done to lessen this? I think you guys kind of just talked about that briefly just now, but is there anything you wanted to add to that?
Yeah, I wish I knew, and you know, lots of smart minds are thinking about this and trying their own things, but you know, it's a biopsychosocial problem, and a problem with the medical system as well, with our healthcare system. So it's not an easy fix. I think, you know, part of the fix is fixing society and our healthcare system and behavior of adolescents and changes in variability in maturation across individuals. So it's a problem that I can't solve by myself, but lots of people with different expertise are going to need to come together for this disease and for any other disease.
Great, thank you. And we have another question from Laura Quill. She writes, at your center, you have made the clinical shift to start your young sickle cell patients on hydroxyurea if they do not have the higher WBC. Seems to me families, patients started at least talking about getting on hydroxyurea earlier may help instead of starting later in adolescence.
Oh, yeah, sure. I didn't really talk too much about the specifics of how we approach hydroxyurea here, or how I would. But it's something that I start talking about at the very first visit. You know, I think whether or not you have severe disease or you think someone's going to have severe disease, this is the one medicine that we have for sickle cell disease. Everybody needs to know about this, and so even at the very first visit, we start talking about hydroxyurea, and we talk about clinical trials, clinical studies of hydroxyurea in the very young child with sickle cell disease for which patients might be eligible. And, you know, the age at which we generally clinically start hydroxyurea, that in everybody's mind, I think, is just inching lower and lower and lower. So, yeah, I think early discussion in pre-symptomatic institution of therapy is the best. I think we still have to bear in mind that unlike other conditions where if we wanted to treat something, you know, stroke, you know, we'd have to, you'd want more than one, two or more high-quality clinical trials to inform your decision. And I think we need to do more clinical trials. We shouldn't give children with sickle cell disease. They deserve the same quality, the same high-quality clinical evidence that any other population has. Now, of course, we run up against the fact that this is an orphan disease, and so it's hard to do so many large clinical trials. But we do at least need to keep in mind, even though hydroxyurea is a good thing, and I prescribe it quite frequently, we don't know as much about it in young children or even in adults as we do about so many other medications given for so many other complications because the number of clinical trials are so few, and that's a problem.
Okay, thank you. Are there any other questions for Dr. Quinn? Looks like Tanya Mitchell has a question. Tanya, if you can unmute your line by pressing *6, you can ask your question directly.
Hello?
Hi. Yes, go ahead.
Hi, Dr. Quinn. You mentioned a number of cohorts, and you were talking about, you know, transitioning and versus, I guess, the highest risk of mortality for sickle cell patients. Mm-hmm. Is there any way to use that data versus, I guess, the mortality information with the deaths of, you know, the different patients to kind of find some predictors?
Yeah, I mean, yeah, obviously. That's a very good question. When we look at the survival curve, I censor it at 18 years, or I censored it at 18 years for the Dallas newborn cohort. Of course, it falls off very quickly after that. Now, part of the problem is as you go further out in time, increasing follow-up, you have decreased numbers of individuals who remain at risk, and so the estimates become so variable. But yeah, I think if you want to further decrease mortality, you're going to have to look at risk factors for those deaths that are occurring in that transition period. So I agree. It's just hard to do.
Okay.
And I think we're probably at a point where this is not something that we can just do with single cohort studies anymore, but a national cohort study or a national registry is where we're going to probably end up having to answer some of the questions that you pose.
Okay, thank you.
I think we have Megan has a question. If you can unmute your line by pressing *6, and you can ask Dr. Quinn directly. Megan, are you there?
Hi, this is Megan.
Yes, go ahead.
I'm a nurse care coordinator in a medical home in Waterbury, Connecticut, and we have the pleasure, I guess, of working with sickle cell families and doing one part of what we do is transition and help the kids to transition from pediatric care to adult care. And as I put in my statement, it's definitely not a perfect system, but getting to know these families when the kids are little and working with them right through adolescence and up to age 21, we do have the advantage of, of being there for them. And so the person that had asked about, how do you deal with transition, I'm not sure where that person is located, but, looking in to see if there's Children with Special Health Care Needs initiative, as there is in Connecticut, may help with that.
Yeah, it sounds like you have an excellent system.
I'd like to think that we have a good system. It definitely, our kids do well in this area, and like I said, nothing is perfect, but it does help to to get to know these families. And many of us who work with the families in this transition role have also worked with the families on an inpatient and outpatient basis. So we've seen them, in their worst, in their areas of pain, when they're in acute chest and when they're hospitalized, and just, during those worst times. And it's nice to see them during the times when they're in the primary care office also, when you can grab their attention a little bit more and talk to them more about transition and how to get through those tough times, and everything from recreational, emotional, psychosocial assistance, everything that we can do for them. We certainly reach out to, community resources, and it seems to work.
Sounds great.
Thank you.
Okay, are there any other questions? We only have about a minute left.
Hello.
Hi, go ahead and ask your question.
Hi. Yes, my name is Olga Mills. Hi, Dr. Quinn.
Hello.
You've been very informative today. My daughter is 27 years old, and she's on hydroxyurea. She started it when she was 14 because that transition from childhood into adolescence proved very, very difficult for her. She was having a lot of crisis, and her doctor decided to put her on hydroxyurea. And it's been working pretty well for her. When she was in college, she was having quite a bit of crisis as well, which the doctor thought was contributed to the stress of studies. But now she's being pretty good on it. But I've been hearing a lot recently about natural remedies for sickle cell disease, and people saying that it's been helping kids, and they would prefer that over the hydrea. What are your thoughts on this?
Well, I would caution you. we don't. There's really no evidence for any of these natural therapies. There are a few out there, but they, from my perspective, I don't care if this is a Chinese medicine or an herb or something. As long as you test that medicine, that supplement, that herb, that whatever, to the same degree of evidence, then I think it's fine to give. But just for those other remedies, there really is no meaningful data other than anecdote that they're effective. And we do know that individuals with sickle cell anemia, the one thing that we can tell you is that if you have sickle cell anemia and you take hydroxyurea, you most likely live longer. We can't say that for any of those other therapies. Now, I'm not opposed to studying any of those other therapies. That's fantastic. We need to study as many therapies as we can in sickle cell disease, but we should only decide to use the ones for which there's the strongest evidence. So I would encourage you to, promote people to encourage people to join clinical trials and ask their doctors about other therapies.
Okay. Thank you so very much. I appreciate that.
You're welcome.
All right, everyone, I'll have to cut us off. It's exactly 3 o'clock. Dr. Quinn, thank you so very much for your time today, and thank you for being flexible for presenting on the first Thursday instead of the fourth Thursday. This session does conclude our 2013 series. Please mark your calendars for 2014. We'll continue to meet on the fourth Thursday of every month through October, and we'll still be on from 2 p.m. to 3 p.m. Eastern Time. We will be publishing the 2014 calendar next month, so look out for that via email. Again, if you have any questions about the webinar series, you can contact me at spope@cdc.gov. Our webinars are recorded and made available at scinfo.org. We are still in the process of posting the webinar from last month, but when you see that, you'll probably see this one as well. So thank you all again so much. Again, Dr. Quinn, thank you for participating, and we hope to have you all on next year.
Thank you. Bye-bye.
Bye-bye.